Hello, my name is Dr. Sarah Walker, and I'm honored to serve as the 2025 President of the El Paso County Medical Society. On behalf of our organization, I want to welcome you and thank you for tuning in to the El Paso Physician. For the past 28 years, the El Paso Physician has been dedicated to serving our community, and we are grateful for the continued opportunity to bring this program to you on PBS El Paso. This would not be possible without the generous support of our community sponsors who help us produce valuable content every month. If you or someone you know is interested in supporting this program, more information is available at 915-533-0940 or at epmedsoc@aol.com. Thank you again, and we hope you enjoy this program presented by the El Paso County Medical Society and hosted by Kathrin Berg.
For many, the word hospice brings fear, uncertainty, and confusion. But the truth is, hospice is not about giving up. It's about gaining something incredibly meaningful, such as comfort, connection, and dignity during one of life's most vulnerable seasons. We're going to break down what hospice really is, why families choose it, and how starting care early can create a more peaceful and meaningful moment in a person's life. This program is underwritten by Hospice El Paso, and a huge thank you to the El Paso County Medical Society for bringing this program to you. I'm Kathrin Berg, and this is the El Paso Physician.
Neither the El Paso County Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Hello, thank you so much for joining us. Today we're going to be talking about understanding hospice. Usually there's a gasp when somebody hears that word. What does it mean? And we're going to break down what hospice actually does, what it does mean to families and to the person who is actually in hospice. Today with us, we have Dr. Juan Becerra, who is the Chief Medical Director, and he's the person that oversees patient care and guides clinical decisions. We have also with us Dr. Jose Burgos, who is the medical director and supports patient care and ensures comfort-focused treatment. And then we have nurse Rosie Bernal, who is the director of nursing, and she leads the nursing team and ensures patients receive compassionate, high-quality clinical care. Now, all of that was a lot of mouthful in speaking of what you all do. So to me, the golden nuggets are always right before this program starts and we have these conversations about what you all do. So what I'd like to do is have you all tell the audience, so Dr. Becerra, as the Chief Medical Director, what does that mean to the folks at home? What do you do all day, every day? And I'm going to ask each of you the same question.
Thank you, Kathrin. Well, my job is to coordinate the levels of care in hospice all across from pediatrics to adulthood. We also select the medications that are supposed to be for the patients on the different stages in their illness. And also coordination with the nursing staff, with the social workers, with our chaplains, the whole team that makes hospice a hospice.
Mm-hmm. Excellent. And Dr. Burgos, how about you? Again, you are the medical director. We've got chief medical director, and we were talking earlier that you do a lot of inpatient, you do outpatient. What does that mean?
Right. So I take care of the Center for Compassionate Care, which is our inpatient hospice unit. And basically, this is the type of patient that has severe symptoms that are difficult to control with our typical medications. Patients who are actively symptomatic and they can only be controlled with intravenous medication. So rather than get these patients back to the hospital, where unfortunately hospitals are not necessarily trained to provide comfort, more to treat aggressively, then the Center for Compassionate Care can provide aggressive treatment for symptom control while preserving that comfort that the patient and family needs, because we not only treat the patient, we're treating the family members at the same time.
So I'd like to expand more on that as this hour goes, because I think that could be one of the myths that we encounter throughout time, because all of us have been in that situation where we know somebody went on hospice, and then I'm just being blunt, then it's like, oh, that means they're going to die soon. And that's not always necessarily the case. And we're looking at treatment within hospice as well. So I'm glad that we're bringing that up. Nurse Rosie. So let's ask you are often, I'd imagine, the first line of the families that come in, and you are the nursing director. So the conversations that you might have with patients and their families, how would you describe what your role is?
Well, I provide support for our nursing staff, our social workers, our chaplains, and our bereavement counselors, our certified nursing assistants. And my job is to support them. When they go out and see patients, they have face-to-face interactions, and sometimes they need the support that amongst each other, because hospice is a hard job. So they all need support from each other, and I like to say I provide support for them too.
You know what? Say it out loud and proud, because we're going to talk about caregivers in a while as well, because that is it's an onus on people, and you all are very good about navigating that and helping out with the caregivers as well. Rosie, I'd like to start with you, and this is the $1 million question of the evening. What is hospice, right? And the reason I'm saying it, and I know we talked about it a little bit before the program started, it seems like such an easy thing. Well, everybody knows what hospice is, but there are a lot of different tentacles that are involved in different ancillary effects. Maybe go through some of those so that people that are listening that may go, oh, I didn't know that hospice did that. So if you can start from there.
So hospice is a program for patients and families, patients that have a terminal diagnosis, a life-limiting diagnosis, and basically what it is, we have team members that go out and see the patients and provide care that we want them to feel comfortable at end of life, have dignity of end of life, and manage their symptoms. There's also, we manage clinical symptoms, but there's also spiritual symptoms.
Symptoms, hard word. Yeah.
Spiritual symptoms, emotional symptoms, and sometimes patients are grieving things that could have been, families are grieving things that could have been. And so we have our bereavement counselors, and we have our chaplains that provide that spiritual support. They are non-denominational, so they can provide care for all patients.
Yeah.
And then we have our social workers that provide emotional support for our patients.
I want to give kudos really to some of the social workers, and I'm just going to use my own experience because I think that's what we all do. We all come from the perspective that we have. I'm from Germany. When my grandmother was 80, we brought her from Germany to live with us here in America. She didn't understand any English, etc. She was at a point where we put her in hospice, and the social worker that we had went out of her way to get books in German, to get, at that time, VHS tapes in German. This was 30 some odd years ago, but really made an effort to make her comfortable in an environment that she was completely fremd to. I'm trying to think of a stranger to, in this area. And it was my first introduction to hospice. I never knew what hospice was. I was, a teenager. And so kudos to that. And I've been always a proponent of anything and everything that has to do with hospice. And I'm going to stop here at this point because I think it's super important for the audience to know that this particular hospice, which is Hospice of El Paso, is the only hospice in town that's a nonprofit. And it's the only hospice in town, Dr. Becerra, that you were talking about, that also treats pediatrics, it treats children. And so on that note, Dr. Becerra, I'm just going to ask, we're going to go off script a little bit and talk about those two components. In fact, I'd like for you to talk about the pediatric hospice portion of it. And Dr. Burgos, if you don't mind, I'd like you to talk about the fact that it's a nonprofit and what does that mean in the space of all the other hospices as well, because there are many to choose from. And I just would think it'd be good for the audience to know that. So talk about the pediatric portion of this particular hospice.
Yeah. The pediatric program is different from a regular hospice that we all know, right? Yes, the pediatric patients are, close to the end of life, right? But a kid most of the time last longer because it's a younger body. That is the reality, right? So for good or for bad, believe me, for good or for bad, they last longer. They're in their hospice benefit. They're able to receive chemotherapy in the case of a cancer. They're able to go to the hospital in the case of a flare-up of, call it asthma or an infection or whatnot, whatever it is, they can still go to the hospital and still be enrolled in hospice care because our goal is to prevent infections, to help them at home with not only their clinical needs, but also their spiritual needs and the family members and everyone else around them. And also the social needs that sometimes families encounter, from financial issues to social issues in general, right? That they have a sibling that needs to go to school, but the mom is always busy at home. So all those things, as you said, kudos to these people that take care of this person. And they ask me, like, why do you do that, right? Well, I don't know. I don't know.
It's a calling.
I do it because it's a calling. I think God put us there for a reason. And yeah, everyone runs away from a house on fire, but we run towards it for some reason, right?
Yeah.
Someone's got to do it. And believe me, just knowing that keeps me going.
And again, my experience was over 30 years ago, and it was for maybe a 6-month period. I'll say this, my mother and my grandmother died within 3 months of each other, and both were on hospice care. And so it was a very big portion of my life. But the change and the impact you had on our family was phenomenal, like truly phenomenal. And I want to say that to people listening, because I think there's a hesitancy to sign on to hospice because it means you're giving up, just like we talked about in the opening statement. And that's a myth we'd like to bust this evening. Dr. Burgos, to kind of counter on that, and I know I said let's talk about the nonprofit arm, but we were also talking about with pediatric care, but also in adult care, you were talking about aggressive treatments that can be done within in-care hospice. Like sometimes people think, well, after hospice starts, then there's no more treatment, or now it's just giving up time. Again, let's bust that myth and talk about some of the treatments that occur while in inpatient care, if that makes sense.
Yes, I mean, typically people say, well, there's nothing else to do. And the reality is that there is a lot to do. The problem is that we just have to change our frame of the situation. We're now probably not aggressively treating a condition. Now we are aggressively treating symptoms. And symptoms are not always physical. They can be spiritual as well and emotional. So this is now what hospice does. We just reframe how we are dealing with the condition. So there is aggressive treatment in hospice in the sense of the symptoms that the patient is presenting. On the inpatient hospice, we aggressively treat pain, we treat agitation, we treat anxiety. We can treat certain type of infections because we do not want our patients who are already declining because of their primary condition to have an infection just, making them crumble and pass faster. So actually we make sure that we can maintain their status for as long as possible, even if they have a terminal condition. So that is part of the aggressive treatment on the medical physical part. But there is aggressive treatment emotionally. I mean, we can run on patients who are in the hospice unit, and our typical perspective will be like, okay, the doctor will say yes or no to this medication or the other, but we get in the middle of family feuds, that they're fighting because it's a very tense moment. We have to do psychotherapy on everybody there, even the nursing staff, right? So we have to play different roles when we are providing hospice care. And I tell this to the family, like, it's not only the patient who is receiving services. Everybody in the close circle is receiving services because it's everybody's problem at the end. So we tend to relieve that weight from their shoulders, or make it a little lighter at least, so they can have a better experience at the end of life, because this is unavoidable, right? Death is gonna come. And a lot of people, and I'm sure that for Dr. Becerra, it's like, well, why are you guys doing this? It's not a glamorous specialty in medicine. And I actually, with years, I have learned to recognize more and more why we do it. Everybody's present when we're born, and we tend to die alone.
Oh my goodness, that's so spot on.
And to me, that is extremely important. We cannot die alone. We cannot die in pain. We cannot die suffering. So we do so much to celebrate birth. We do so much to fight death when we are treating patients in the hospital, when we prevent diseases. But what about at the end of life? We have to recognize that the life will come to an end. Sometimes it is, most times it's unexpected, and we need to be there.
Yeah, I agree. Rosie, I'd like to take that a little bit further in the mental health field in treating. I know we were talking about social workers and faith leaders in the world of end of life. We talked about anxiety, we talked about depression a little bit, but I'd like to focus on that for a while because, again, that is what people think of. You can't help but just be completely down and depressed when you know that your life is going to end and the people around you. And that was a big part of the treatment with my parents when we were going through this. Talk to the audience a little bit about what is available when someone is in hospice with those issues.
We do have, for example, our chaplains, they try and take care of spiritual pain. It can be very hard when you're dying and you're asking yourself, why is this happening to me? And so we have our chaplains that have experience with patients that are dying. Our social workers are amazing and they provide emotional support. And sometimes it's amazing what venting can do for a patient or a family member. And so we have patients that have a lot going on in their mind, and our social workers are there to listen. And they will listen, they'll take what they hear, and then they'll try and help them that way. And then it's not always about sadness and anxiety and depression. Sometimes, or a lot of times, we're there to control symptoms so that they can live comfortably at the end of their life. So we would treat pain so that they're able to enjoy their time with their family. We treat anxiety for the same reason. They can enjoy their hobbies at the end of life. So all those services that we provide is for us to be able to give the patient's life meaning at the end of their life.
That makes sense. Dr. Becerra, what I'd like to do is, I know we've kind of answered this here and there, but you are the physician. When you talk to a family that is in that really difficult stage of, do we decide to go with hospice? Do we decide not to? Again, kind of dispanning myths and what you've heard and what it is. What are, and I'd love to hear maybe some experiences that you've had, some case studies perhaps of a family that was kind of fighting going in, like, I'm not sure if we want to do this. What are those conversations like? What is it that they ask of you? And how do you explain how getting into office and why you should be getting into hospice?
It really is an art to convey that message. It really is something that is very intimate from not only from a person to person, but also there's cultures around these things, right? You mentioned that you're German. The perspective of death and life, obviously, in the German community will be different from one that is a Jewish community or Islamic community. So you have to, it really is a social skill. You have to read the room, and then you have to talk first to the patient, obviously, right? We have to respect the patient always, talk to the patient. And if not, maybe you have to address yourself if the patient is not able to make decisions, to the chief of the family, maybe, right? Our laws in Texas, they tell us who to talk to, who to address to if they don't have the decision making, if the patient doesn't have the decision making. So you have to start there. And then you have to make a diagnosis based on the prognosis, where you have to tell them what to expect. Ma'am, if the patient is there, right, talking to you, you have this condition. It's a terminal one, right? So it means that it doesn't have a cure. You have this much, maybe if you have a good estimate of time, you have to convey the message with all the compassion in the world. And if they want to, right? As I'm telling
And
you,
that's so key. And if they want to, I feel like we were saying that, but how often is that a struggle? Is that often a struggle, not often a struggle? And I guess it depends on, like you said, the chief of the family, so to speak, right?
surprisingly, most of the patients, whenever they know that they have something terminal, they want to know how long.
Okay.
They want to know how long because, hey, you have to be prepared, right? You have to.
And
be
how can
prepared
you answer that? That's the hard thing too, right?
Based on our experiences, right? Yeah. Based on our experiences or previous patients, every patient gives you, another lesson to learn as a physician, so you can be better prepared, more accurate for your prognosis, and to tell them what to expect in future cases. And so you convey that message to them with all the compassion possible, with all your social skills, and then they pick what to do, right? And it's okay, you have to address it, that it's okay to not let go or not to feel that they're failing, right? I don't like whenever someone says, oh, you failed chemotherapy. You failed your therapy. No. It's not failing. It just, as I explained, medicine has three purposes. The first purpose of medicine is try to cure you. We try to cure you. But hey, sometimes because of the type of illness, we cannot cure you. So you shift your care, your efforts to the second purpose of medicine, which is prolong life. Maybe we're trying to prolong life with chemo, with the treatments for COPD, for heart failure, for ALS. And then if we cannot prolong your life, or prolonging your life means making you suffer, we shift our care to the third and last purpose of medicine, which is avoiding suffering, which is what hospice is, right? But it's not failing, or it's not, quitting. They're never quitters. It's just directing your medical efforts and your efforts as a patient towards a different purpose.
That's beautifully explained. Dr. Burgos, if you can, and this is the hard part because it's kind of the clinical question there's all kinds of different situations, and I get it. But when is it the time that you would tell a patient it's time to go in hospice? And I would like to, not emotionally, but clinically. And maybe you can give some examples of, you talked about ALS, you talked about certain types of heart disease, et cetera, certain types of cancers, oncology. When is it clinically that you all make the decision amongst yourselves of like, this patient should be approached, or this patient's family should probably be approached to consider hospice care?
Definitely. Actually, there is one important thing. In the United States, hospice is regulated by CMS. So everybody follows what CMS makes a standard. And
what is CMS?
Centers for Medicare and Medicaid Services.
Okay.
So it's the federal government, right? Because obviously most patients in the country, they can be insured by the federal government with either Medicare or Medicaid. So they set the rules. And this is a very regulated program. A lot of people think, you guys want to put me in hospice because it's a business. And I actually tell them, well, if I actually make the wrong call for secondary gains, I'm going to be in trouble. And not just in trouble for, somebody's going to like slap my hand. I'll be in trouble with the federal government because it is a heavily regulated program. So the rules in the US, they tell us that somebody qualifies for hospice is if the condition they have has a prognosis of 6 months or less, if it follows the natural course of the condition. So this is something that we always have to reinforce when we document how the patient is doing. So that is the strict criteria. Now, sometimes we can see a patient in a certain condition and we know, well, I mean, if this continues to go this way, we know that it's not 6 months, it might be weeks or days, so hospice is appropriate. But if the patient recovers and they still have the terminal diagnosis, they may actually outlive the 6 months. So they can still be within the realm of receiving hospice services, and they can actually surpass that expectancy of 6 months or less. We have patients in hospice who survive over a year. So we have to always reevaluate, do they meet criteria or not? Do they have evidence of declining through the past 3 months, or are they actually getting better? And you know what? Sometimes a lot of patients with terminal conditions or with severe chronic conditions, all they need is a little bit of care. And with the care provided by hospice services, some of them, they tend to do so well that the prognosis is overextended, so we have to interrupt and stop services because their life expectancy just went above of what we thought would be initially.
So in that unique case, when someone is in hospice and the expectation was 6 months or less, and it now looks like things are getting better, there's a rallying happening, and that person looks like it's going to, maybe live quite a bit longer. How do you all handle that? You said sometimes they go out of hospice or into something else. How does that cadence work when that happens?
We have to do certain processes. They are called recertification processes, and we do that every 2 to 3 months, just to see how the patient is doing. So if on a particular recertification period, we're seeing that the patient is actually quite stable, it's not needing pain medications anymore, it's gaining weight, it's not falling, hasn't needed to go to the hospital accidentally because something happened in the middle of the night. So we kind of like flag the patient and say, okay, for the next couple of months, let's keep close eye, because once we are recertifying again, maybe they might not meet criteria. And then at the same time, we have to let the patient and the family know, because a lot of people, they get so comfortable with the services that if we have to drop them, they will have a really hard time. Because it is a net where they are falling, and it's holding them, and it's holding the entire family at times.
Mm-hmm. And we were talking prior to the program too, that being in hospice, and this is a great example of that, doesn't necessarily mean that you're married to hospice. If you on your own want to unenroll in hospice, that's something you can do as well. Or if medically things are going well, that can happen as well. And I'd imagine too, and Rosie, you can speak to this, that if and when that does occur, there is still some support, obviously, in service that might help out. On that note, and I think this is the question that everybody asks, and Dr. Becerra, I'll ask you first on this. When it comes to paying for hospice, when it comes to the fact that Hospice El Paso is a nonprofit hospice, does that make a difference in the paying of hospice? How much do people pay for hospice? Is it different according to insurances, et cetera? It's always the hard question to ask medically, but that's the question everybody's curious about.
Yeah. It's 100% covered by Medicaid and Medicare, and most commercial insurances. And I dare to say maybe 99% of them right now cover the hospice benefit, because everyone recognizes the benefit of it. These type of patients will end up eventually in and out of the hospital, producing a lot of debt in the families, and then obviously the insurance companies are going to have to pay a lot for these patients, right? So whenever we enroll the hospice benefit for these patients, it's 100% covered, so they don't have to go to the hospital anymore, which we know that eventually they're going to expire because they have a chronic, life-limiting medical condition. No one escapes that. Just focusing the care on comfort it's a win-win-win for everyone.
And Rosie, let's talk about, we've talked about the idea of when it's that time. And now a family comes to you and comes to Hospice of El Paso, and it's time to enroll them, admit them into hospice, et cetera. And one of the myths is that, if I'm gonna go into hospice, that means it's gonna speed up my dying process. I'd like for you to address that bluntly and specifically, because I think that needs to be addressed. And again, there's myths out there because I heard this and I heard that. Well, I remember this and I remember that. And it's always, not always, but often from a second hand or a third hand or something happened 20 years ago, et cetera. So tell us really what that means.
When you come into hospice, it's not about expediting death. What we are focusing on is quality of life at the end of life. It doesn't mean that the patient is going to pass away sooner because they're in hospice care. What happens is that we treat patients for, say, pain, anxiety, with medications, and a big myth is that those medications cause death. And it's not the medications that cause death, it's the actual disease that causes death. But it doesn't mean that they're gonna die as soon as they go into hospice. These, when we admit the patient and they're talking about, do I have to give this medication to my loved one even though they might not need it? And the answer is no, you don't have to give the medication if they don't need it. Sometimes they think, oh, they're in hospice, I need to give them their medications no matter what. But that's not the case.
So expand on that. So that is the doctor's directive to give a medication, but then the family can decide not to do that in hospice? Like, expand on that a little bit.
So what happens is that a nurse will do their assessment and then report back to the doctor. Then the doctor gives us the orders to incorporate a new medication or stop a medication. We get those orders and then we educate the family on the medication. We'll order
Because it may
them
be a brand new medication they've never heard of before, or
Right.
understand how the reaction will be. Okay.
Yes, and so we educate the family what the medication's for. A lot of the times the medication is used as needed. And so we educate the family. You only give this as needed. So say...
And give us an example. I know I'm interrupting, but that way we can be specific on that. So when you say as needed, is that usually a palliative medication, meaning a medication for either pain or medication for sleeping? What family is the medications in that you're speaking of?
For example, pain medication.
Okay.
We provide pain medication, the doctor's ordered pain medication, and we teach the family that if the patient has pain, then that's when you give the medication. If they don't have pain, then we don't give the medication. Another medication that we may use would be anti-anxiety medications. As our body starts shutting down, we get anxious, we get scared. And so during that time, if the patient gets anxious or scared, then we'll use the anxiety medications as needed. Sometimes we don't get scared. Sometimes we're ready to die. And so we're at peace with it and we don't need the anxiety medication. Another one would be shortness of breath. That happens at end of life too. We will provide oxygen or even something like morphine to help relax the patient's diaphragm and help the lungs breathe better. And so we'll talk to the family about that too.
So this is the stuff that I think is so important for the audience to hear and know, because when a family is in that situation and the family is making decisions, and I'm going to the point again, I'm thinking about my mother in this point. She was in a coma-ish for the last 4 or 5 days. So there was not something that she can make a decision on. So the family had to make decisions there with the help of the nurse that was there. And again, this is 30 some odd years ago. It's been a long time. Have you been in a situation in the past, and this is again where we can talk about real life case studies, where a family was like fighting, and you were talking earlier too, that sometimes there's infighting within family members. Some say, yes, let mom have the medication, it's gonna help her feel better. The other ones, no, it's, talk a little bit about that struggle and how you all handle that, because that's again a real life situation I'd imagine happens quite a bit. How do you all handle that?
So sometimes we'll have a family and a patient that have been through a lot of struggles to get the patient into hospice. They might all agree. But then we have a daughter or a son that lives out of town, and they see the bubble that the patient and the immediate family has been in, and they say, well, you're giving up. Why aren't you treating my mom with more chemotherapy and more radiation? And so what we do is we encourage the family member to come and visit the patient and see the dynamics of what's going on with the patient. And then we educate. We educate on what's going on with the patient, how their body is shutting down. And at that point, most of the time they understand, and then they're ready to accept hospice and to accept the treatment that we offer.
Okay.
And you know what? We follow a hierarchy. There is a chain of command. Patient rules. Patient is the one who makes the decision.
There you go.
And then if the patient is not able to make the decision because it's numbed by the condition or the status or even because of the medications, then we go to whoever has medical power of attorney. So even if you have 10,000 family members fighting, you just tunnel vision to go to the person who makes the decision, and you tell them, this is a legal situation, and this person is the only one who has the capacity to communicate anything. So they have the right to communicate with all the other family members, or they can make decisions on their own, but legally that's the only opinion that we will take. And then when we don't have a paper telling us who makes the decision, then we go to the next of kin, and then that's when we have to play referee among brothers and sisters. And even if there is one person legally capable to make decisions, it's always good to try to bring everybody together so they can all be in the same page. Just because, it's a tough time and you want people to feel at ease.
Right. I will interject here. I was in a difficult situation. My birth father, who I was completely estranged from, I was the next of kin. There was no paperwork about who to call, et cetera, and I just got a phone call one day. It's like, hello, Kathrin Berg, are you the daughter, are you related to this individual? I was like, he's my biological father, yes, but there's no. So I was put into that situation, and all of a sudden had to make decisions and I had no idea. Again, hospice was it was a different hospice, it was a different city and a different area. But I do have to say at that time too, that I'm a proponent of saying that this is something that they help you out with all kinds of different steps. Dr. Becerra, I would like to ask you, and again, this is not a myth, but just the understanding. There is end-of-life care. We hear the word hospice, and then there's also palliative care. Palliative care just basically means taking care of the pain, so to speak, the lessen the agony. And you said that earlier, it's medication or medicine is for cure, for prolonging life, and then avoid suffering. If you could explain to the audience within the auspice of hospice, the way those two compare and contrast with each other.
Yep. So the word palliative means to cover with a piece of cloth. Is to cover, to make it feel better, right? Mm-hmm. That's where the linguistic word comes from. Mm-hmm. So what that means is that every person, not only a clinician, a physician, or a nurse, or anyone else, but any person that puts a Band-Aid on someone is doing a sort of palliative act towards someone. helping feel better. No?
Yeah.
So as in medicine, every time that we give, for example, someone that has a cancer, a pain medication because they're in pain, you give them a pain medication. Or every time that a lung doctor gives an inhaler to someone that has COPD, for example, they're doing an act of palliative, right? But as those conditions continue, maybe that cancer, instead of being a stage 1 cancer, became a stage 3. So as a tumor grows, for example, or that COPD got worse, or that heart failure is worsening as well, that is causing the patient to have a lot of liquid in the lungs or in the legs, you find yourself as a clinician giving more and more and more medicines or interventions to cope with symptoms, right? So more palliative approaches. But then at some point, because these conditions might become terminal, that's stage 3, maybe it's a stage 4, which by definition doesn't have a cure in a case of a cancer, then you find yourself doing only palliative approaches because the patient is so symptomatic that there's nothing that I can do as a clinician to prolong this patient's life or to cure them, right? So whenever you encounter yourself in that area, as we discussed before, we have to have that conversation with the family. And that is when hospice will start. When all interventions are exhausted to prolong life or to cure you. So all our efforts are merely with the intention of keeping you comfortable. That is the distinction between palliative and hospice care. So you can see as palliative is what comes before, right, when you're trying to prolong your life or cure yourself. And then hospice is merely palliative measures without anything to prolong your life, right? We don't accelerate death. That is illegal in the state of Texas. It's legal in other states, right? That is a topic that would be, for hours and hours.
Since we border New Mexico, Arizona, and Mexico, because again, this is kind of our community, where does Mexico sit on that, and where does New Mexico sit on that?
There's 8 states in the nation that allow physician-assisted suicide, and New Mexico is one of them, right? So yeah, it is legal.
So is there and I'm going off topic just because we brought it up, and I'll just spend a second on this because we've got people in Las Cruces and in El Paso. So if someone was going to choose a hospice in Las Cruces or in El Paso, is there a fundamental difference in policies because of that law, or is it not?
Well, even a hospice in New Mexico does not provide physician-assisted suicide. Hospice does not do that because, as I said, the hospice philosophy is not to hasten nor prolong death. What those states do, especially, not especially, but also in New Mexico, is that a physician that is okay, that is treating the patient, and the patient expresses twice that he wants to terminate his life in the best way possible, that physician could, if he's okay with it, prescribe a medication that is lethal at that dosage. But the physician does not give the medication to the patient. The patient has to give the medication to themselves.
Okay.
That is what it's legal, right? If I, as a physician, give the medicine to the daughter or the husband of a patient, and that family member provides it to the patient, that is illegal.
The patient themselves has to
Exactly.
administer the medication.
Otherwise, it will be manslaughter.
Okay. Otherwise, it would be manslaughter.
Yes.
Yeah. Okay.
Very, very
I would love
case.
to one day do a program that, again, because it's a part of the conversation often when there is a terminal illness. So I appreciate us bringing that up. Dr. Becerra, I'm going to ask this of you. It's originally Rosie's question, but it's your turn. So when we're talking about a hospice plan of care, like a care plan in hospice, describe what that might be. And again, I know it's different with everyone. If you want to use a case study, great. But in general, someone is newly enrolled into hospice and now we have a plan. Describe what that could look like.
So the plan of care is a multidisciplinary approach. And actually it's between the doctor, the nurses, the CNA, the social workers, the chaplain, the volunteers, the bereavement coordinator. So it involves so many people. So obviously from the medical part, then we assess what needs they have, right, based on the diagnosis. Maybe it is to improve the respiratory status, so then we tend to prescribe medications that will help the patient breathe better. Dealing directly with the condition, maybe it's treating pain, maybe it's treating nausea, vomiting, anxiety, agitation. And then at the same time, it's addressing what other social and spiritual needs the patient have. For example, something as simple as has the patient, is everybody who he cares about around? Are they here? Now, you know what, there is a son that he hasn't seen or spoken to in 15 years. He said, you know what, I think it's time to kind of like connect this and see if there's something we can do to mend that relationship at the end. Exactly. Are there any spiritual needs? Is there any guilt being carried? So even those simple things, they are extremely meaningful in the process of death and the end of life. So we address all of those things, and that's part of the plan of care. Or it could be something as simple as how many volunteers do we need to keep the patient company because there are no relatives around. Yes. Yeah. Right? So we want to make sure somebody, and you will be surprised how many people actually volunteer for hospice.
I'm not surprised at all, actually. I understand it and I get it.
Right.
You know, yeah.
So that is part of plan of care. So it's what are the needs and how can we make this process the least, anguish for the patient or the family member.
And I like how you're talking about, sure, it is physical comfort, but it's also emotional comfort. Definitely. And mental comfort. And that's something that is highly focused on. And I think that's great. And on that note, Rosie, I'd like to talk a little bit about the caregivers and how you all implement caring for the caregivers as well, which I think is highly important because they're the people that are there 24/7 and, deal with the hard stuff. Talk a little bit about how your hospice deals with that.
We provide support to the caregivers by, of course, education, how to take care of the patient. We encourage them. When they're doing a good job, we let them know you're doing a good job. You're taking care of your family member. We also teach them to take care of themselves because if they don't take care of themselves, then who's going to take care of the patient? We do provide respite care for our patients and their families, which is...
Describe what respite care is for those who don't know.
Right. What we do is we send the patient to our inpatient unit so that the caregivers can get a break because taking care of a dying patient is hard. It's very hard. And so the patient can go to the inpatient unit for, I like to say, 5 nights and 6 days. And they go so that the caregiver can get some rest. And the patient receives 24-hour nursing care, which includes the CNA, a registered nurse, or a licensed vocational nurse.
Okay. And that's a perfect transition. And Dr. Burgos, I'm going to ask this of you. The question comes up, well, now they're in hospice, on hospice. I don't know if there's one that is in place of the other, but where does hospice take place? There's inpatient, there's outpatient, so it could do it at home, could be an in-facility, et cetera. How is that decided upon? And just expand a little bit on that.
So ideally, hospice should happen at home because we want the patient to be as comfortable as possible. But sometimes it can happen for different reasons. Maybe they need 24-hour care, they cannot be independent on their normal living activities and they need more support. So that's when we do hospice either in a foster home, which is a private pay home, or could be in a nursing home. But if the patient has severe symptoms that can only be treated with intravenous medications, that's when we provide care in our inpatient unit. But certain hospitals, they can provide that care inside of the hospital for a brief period of time to treat these aggressive symptoms. So hospice can happen pretty much anywhere that the patient and the families decide.
We even have patients in jail, in
Oh, my
correctional
goodness.
facilities on hospice.
Huh.
No, everyone has the right.
So this is actually that time in the program where I just ask about the unique things, the new things happening, stuff that we haven't talked about yet, and that's something we haven't talked about yet. How is that carried out? If someone's in jail and they're on hospice care?
If someone has a life-limiting medical condition, even if they are in a correctional facility, they have the right to just receive this type of approaches, right? So if the need be, we will do it.
Okay,
We will do it.
interesting.
Someone has to.
So we are at this point now, we have a whopping 7 minutes left in the program. So this is usually when I like to pull back the questions that I have and see if there's anything that you all wanted to talk about this evening that maybe you thought about on the way over here that I didn't talk about or ask you. And whoever raises their hand first gets to go first. Yes, Dr. Becerra.
So I know your audience includes physicians, right? And it's my mission, I feel, to convey the message of the beauty of palliative and hospice care to our medical community as well. And I train students and I tell them, if you don't learn anything from here and you go to be a surgeon, if you get to be a radiologist, whatever you decide to go in this beautiful world of medicine, just know that we as clinicians, as a nurse, as a doctor, we have to recognize when to stop. When to stop offering things that probably won't benefit a patient anymore. It is out of the kindness of someone's heart to recognize that. So that for me and for your audience, I think we all should do that introspection and recognize it and convey it with a lot of, as I told you, a lot of empathy and a lot of caring for our patients.
And I like the way you said that too. And I've heard this over and over again, that often people will keep someone viable for themselves, but not for the patient. And so to kind of step into the idea of what the patient might want versus what the family is fighting for at the end, that's the way I described it. Again, I had 3 parents that were on hospice, and it's I get it. I really do. Dr. Burgos, anything on your end that you'd like to talk about?
Several things. We have a lot of experiences and information, but something important. In the community, we have several hospice companies, and actually everybody can potentially from time to time take a little break and say, well, we can do a charity case. But the difference with Hospice El Paso being the only non-for-profit hospice agency is that we can take on any unfunded patients at absolutely no cost at any time. So that is definitely something that differentiates the company with everybody else. Again, in the community, a lot of people, they do tend to, lend a hand whenever it's needed, but this is the mission for Hospice El Paso.
Okay, so we talked about if there is an insurance, Medicare, Medicaid does cover it, most insurances does cover it, but in case there's someone that does not have the insurance, that you all are the ones that cover that. And again, as a nonprofit, I'd be remiss in not saying, hey, if you want to help out this situation, by all means do.
Exactly. And then another thing, whenever the insurance pays for hospice, just to make it very clear for the audience, there is no co-pay for the patients or the family.
Okay.
This is extremely important to remind our public, because we do not know if at some point in time they encounter an agency that might be charging, and that is wrong, is illegal. That's not supposed to happen. There shouldn't be any exchange of money between a patient and a hospice agency.
Okay. Clear enough. Anything you want to add in your whopping 2 minutes?
Can I tell you a love story?
Yes, you can tell me a love story. Absolutely, you can. Go, Rosie, go.
I had a patient that she had Alzheimer's, and the patient's husband loved her so much. And the patient's husband was not in our services, but he did suffer a fall, and he broke his hip. And he had complications due to the fracture of the hip. And he ended up in the hospital, of course, and then he was transferred back home. And he was placed in hospice. And so their caregiver would tell the patient's husband, you have to be strong, you have to keep going, because the patient, his wife, needed him to be there for her. And he said, no, don't worry about that. I'm gonna take her with me. And so the husband passed away, and then the following day, our patient passed away too.
Oh my goodness. Those are the stories that movies are made out of, and those are the stories that again, this is what it's all about, right? Making sure that people have dignity and care and warmth in the end of their days. Thank you for sharing that. Really, really.
I want to add a
yes.
story there that I think people are going to like.
You have to do it quick.
So when we do interdisciplinary meetings, which happens
Yes.
weekly, we tend to learn about every single patient in the agency, right?
Yes.
So something that is very typical that happens with patients who are really at the very end is that they start having visions of people who they actually love. Yes. So some of them is a parent, some of them is a kid, some of them is actually a brother who passed. But it's not random. It's not a random thought of like a random family member. It's people who meant something very particular for that person. So obviously we believe that person, when they start having visions, we know that it's very, very close, because obviously we want to believe that person is coming to pick them up. So it happens every single day.
What a beautiful note to end on. Really, I hope that happens when it's my time.
Yes,
I would
I
like
agree.
someone to welcome me and
I
bring
told
me.
my doggy before he passed that he needs to pick me up.
Oh, I love that. Goodness. And I'm glad that we all smile at the end of this episode. If you are just now catching a part of this episode and would like to watch it again, or any of the programs that we have done here with the El Paso Physician, this particular program was Understanding Hospice, and it was Hospice of El Paso. But you can go to several places to do that. You can go to pbselpaso.org and just look up on that website, the El Paso Physician. You can also go to the El Paso County Medical Society website, and that is epcms.com. And then YouTube. Everybody always just thinks YouTube. Go to YouTube and just type in the words, the El Paso Physician. You don't have to use that anymore. You can just put El Paso Physician. Automatically, this one will come up first because it's the latest episode, but you can also research other episodes of this program that you'd like to see. Thank you so much for joining us. I'm Kathrin Berg, and this has been the El Paso Physician.
The El Paso County Medical Society is a nonprofit organization established in 1898 that unites physicians to elevate the health of the El Paso community. We have been bringing the El Paso Physician television program to your home for the last 27 years on PBS El Paso. If you should have any medical questions relating to this program, you may email us at epmedsoc@aol.com, and we will try to have our experts answer your questions.